Okay, so good morning, everyone. Today, as part of our Journal Club session, we'll be talking about first-line treatment options for PD-L1 positive advanced non-small cell lung cancer. My name is Hassan Abushukair, visiting medical student at WashU from Jordan. So the paper that we're going to be talking about today is basically a clinical trial comparing tiragolumab plus atezolizumab versus placebo and atezolizumab in first-line treatment for PD-L1 positive non-small cell lung cancer as part of the CITYSCAPE trial, which is a phase 2 trial, double-blinded, randomized, controlled trial, led by Dr. Chu and colleagues from South Korea and sponsored by Hoffman, LaRoche, and Gene Tech. Okay, so this is an overview to the subjects we're gonna tackle today. To start with the background, I'd like to keep the PICO model in mind just to help us navigate through this interesting trial. So to start with, the population here we're talking about is locally advanced, unresectable or metastatic non-small cell lung cancer. So what's the standard of care in this specific population? Looking at the NCCN guidelines, you can see here the molecular biomarker-directed therapy. We have a bunch of targeted therapies for specific mutations, specific genomic alterations like the EGFR, ALK, and so on. And here we can see the PD-L1 specific section, which is based on PD-L1 expression. And I just want to comment on this. This is based per the NCCN guideline, the tumor proportion score, which a quick reminder is mainly based on the PD-L1 staining in tumor cell, as opposed to the CPS score, which includes tumor cells and immune cells, or the immune cell score, which only relies on the immune cells. So using the TPS and the cutoff point of 50%, we can see here that for adenocarcinoma, squamous cell carcinoma, and adenocarcinoma, first-line treatment preferred atezolizumab. It is considered category 1. It is an anti-PD-L1 treatment, so it's an immune checkpoint blockade therapy. What's the category 1 treatment? It is based upon high-level evidence, and there is uniform NCCN consensus based on that. What's high-level evidence? Quick reminder for the evidence-based medicine pyramid. Here we can see for the primary studies, we can see on top the randomized controlled trials being the best type of evidence. So this atezolizumab recommendation was indeed based on the phase 3 Empower 110 phase 3 trial, which compared atezolizumab with chemotherapy in PD-L1 positive and CLC unresectable patients. Okay. And we can see also it is category 1 recommendation for squamous cell carcinoma. So we establish what we are comparing to, which is atezolizumab and placebo. And our intervention of interest, it is tiragolumab, which we can refer to as tiro, and atezolizumab referred to as tizo from now on, tira plus atezo. So we got a sense of what atezo is. So what is tira? Tira is simply an anti-TIGIT. TIGIT is also like PD-1. It is a checkpoint gene, a checkpoint protein that simply helps in normal settings prevent any autoimmune activities. So no T cells attacking the host tissue. However, in the setting of cancer, we can deduce that this might not be what we prefer when we're talking about getting the cancer out of the system. So how does TIGIT inhibit the immune system naturally? We have activities on different pathways. On one hand, we have T cell, natural killer cell inhibition, immune suppressive dendritic cells, T regulatory cell stability, inhibition of the CD22/6 signaling. So all of this through the anti-TIGIT, we can sort of remove the brakes of the immune system as we're used to with PD-1, PD-L1, and try to eliminate the cancer cell. So we know what tiro is, we know what atezo is, but what's the rationale for combining those two agents together? So on one hand, simply TIGIT is an immune checkpoint, PD-1 is an immune checkpoint, so combining both would lead to attacking this cancer through multiple immune evasion pathways, which makes sense. On the other hand, there's a specific strong correlation between the expression of TIGIT and PD-1. So intuitively, we can say that patients with high PD-1, PD-L1 expression can also be high expressors of TIGIT, which allows for more areas to attack this tumor Also, preclinical models showed synergistic effects specifically between those two, and they were well-tolerated combination in phase 1 trials. So the objective of this specific trial, the CITYSCAPE trial, which, by the way, I navigated every web page trying to know the rationale for the naming. I have no idea. If anyone has any hints, can tell us. The objective was to evaluate efficacy and safety of tira plus atezo versus placebo plus atezo, first-line treatment for patients with locally advanced unresectable or metastatic non-small cell. And the other objective was to assess PD-L1 specifically as a predictive biomarker for this regimen. Okay. Moving to our method section, CITYSCAPE, as we said, is a phase 2 trial comparing those two regimens. And it is a multi-center, including 41 centers from 6 international countries. It is a randomized trial, 1-to-1 ratio, double-blinded, so the investigators and the patients were not aware of the regimen they are currently on. And it was placebo-controlled, so the control arm had atezo standard of care plus placebo. And I would assume in this setting, it was considered a phase 2 mainly due to the sample size limitation and the power prerequisite for this trial rather than a phase 3. The eligibility criteria for patients to be enrolled in this trial include first, locally advanced unresectable or metastatic non-small cell lung cancer. So the majority were actually stage 4, but there were some unresectable in stage 3-2. Treatment naive, PD-L1 positive, and here this is an important point that we're going to circle back to. Positivity was defined as TPS more than 1%. Age more than 18, ECOG 0-1, and EGFR and ALK negative, which I found it interesting since they didn't include other targetable patients such as the NTRK and so on. They limited only to those targets because actually in the guidelines it said that if the patient has one of those, the thought process is to go for the targetable agent, then to go for the checkpoint blocker, as well as no symptomatic, untreated, or progressing CNS metastasis patients. No history of autoimmune or hyper sensitivity disorders, because it can simply make the patient more prone to immune-related adverse events with the checkpoint blocker therapy. Okay, so the treatment plan was in Group A, we had patients taking tira 600 milligram, atezo 1200 milligram, IV every 3 weeks, and the control group had placebo and atezo 1200 milligram as well, IV every 3 weeks. And the treatment would go on until disease progression per the RECIST criteria or loss of clinical benefit, which was had a specific definition for this trial setting. And RECIST assessment was done every 6 weeks in the initial part of the trial, and adverse events were assessed using the common terminology criteria for adverse events. Quick reminder of the RECIST criteria: complete response, complete disappearance of all lesions upon imaging. Partial response, we have more than 30% decrease. Progressive disease, more than 20% increase, and stable disease is basically between those two. Okay, so the primary outcome for this trial was efficacy reflected in objective response rate, which is the sum of percentage of patients achieving complete and partial response, and progression-free survival, which is also an interesting point as they used it as instead of overall survival. We'll get to that as well. Secondary outcomes included safety, duration of treatment, as well as overall response. And the primary analysis for this trial was actually planned after the occurrence of 80 events, whether they were progression or death. Okay, so moving on to our results section. What do we have in? So patients were recruited between August 2018 to March 2019, and this resulted in the recruitment and enrollment of 135 eligible patients. Here are schema showing us 275 were initially assessed, eventually 135. 67 underwent the tira plus atezo regimen, and 68 underwent the placebo and atezo regimen. And here we can see that after the primary analysis, only 32 of the atezo group were still on the treatment, whereas 19 were still on the placebo and atezo treatment. But the analysis was intention to treat analysis. So all those patients who took at least one dose were eventually included in the analysis. So I think a lot of time with all these trials, table 1 baseline characteristic can help give us a good idea of what's going on. So looking at table 1 here, we can see that the age almost exactly the same. Sex distribution, there was a higher percentage of males in the placebo and atezo group, which was interesting. For some reason, there's a patient with ECOG too, although they said they're only going to take 0.1. The nicotine exposure was, I would say, higher in the placebo group. Primary PD-L1 sampling was based mainly on primary tissue. And this is an interesting point that also we're going to circle back to that PD-L1 tumor proportion score was, we have 4 categories, 1 to 49%, more than 50, more than 75, and more than 90. I think this is an interesting point because in a way, categorizing the PD-L1 expression into using a certain cutoff point, I think it comes with its own pros and cons. Pros, for instance, it is more practical to translate it to the clinical side. If you have a patient that higher than this cutoff point, eligible, under this cutoff point, they're not. But if you have like a quantitative value, then maybe you have to integrate it into an equation, then you have the likelihood of response. So it is practical. But on the other hand, it might leave some room for misinterpretation because we don't know the exact clustering of the patients in terms of the expression. So for instance, yes, we have more than 50%, 29 patients, but from those 29, actually, almost 65% of them are in the higher than 75 group, and actually almost 30% are higher than 90. So this begs the question, are those outliers with high PD-L1 expression actually driving the response rather than the proclaimed group of higher than 1% or higher than 50%? So this is not an issue specific to this trial, but I would say it is a common theme in the PD-L1 conversation that perhaps needs reconsideration. As we can see here, those who are higher than 50, almost 65% of them are higher than 75, and 14 of those are higher than 90. Okay, we'll get back to it. So in terms of results, after the primary analysis, which as we said was done after 80 events, with a median follow-up of 5.9 months, objective response rate was 31% with the TIRA and 16% with the atezo, which was significant. And the PFS was 5.4 months in the TIRA atezo versus 3.6 months in the placebo atezo, which was also significant with a hazard ratio of 0.57. With the unplanned updated analysis, which was with a median follow-up of 30.4 months, also the objective response rate was 38% with the TIRA atezo, 20% with the placebo atezo. And here we can see the interesting trend. In the higher than 50% group, the response rate is 69%, whereas for placebo atezo 24, 1 to 49 is almost the same, 16%, 18%. Duration of response for the entire cohort, 17.6 months in comparison to 10, which 7 more months with the TIRA atezo, and PFS was also the same, higher in the TIRA atezo, 5.6 compared to placebo atezo. I think there's an interesting point here that the previous slide was based on 6 months of follow-up, and we had a 31 response rate. And for placebo atezo, I forgot the percentage, but after an additional 24 months of follow-up, only 7% had additional objective response rate. So I think this maybe also points to the fact that maybe having a fixed course, I know this is like premature discussion, but like having a fixed course of the drug, maybe in the future on the horizon can be something we consider, because as you can see, the additional risk of 2 years of the regimen and its adverse events only translated to an additional response rate of 7%, which I found interesting. In terms of progression-free survival, okay, so here are progression-free survival, Kaplan-Meier plot, the TIRA and the placebo group. It was actually significant after the extended follow-up, and this was for the total patients, and the figure 2B is for overall survival, which was actually not statistically significant, although the trend was there. In terms of PFS, when we stratified based on TPS expression, higher than 50 was indeed significant, whereas the split was not visible for the 1 to 49%. Overall survival, almost the same trend. We have a significant difference in the higher than 50. The difference was not detected in the 1 to 49 group. In terms of safety, treatment-related adverse events was higher with the Tizo group, 82% versus 71%. And the most common grade 3 or higher adverse events was actually lipase increase, which was in 9% of Tira, whereas the 3% in placebo. This only occurred in the Tira and the Tizo group, and they were one of them was due to pyrexia, and the other was due to EBV infection. And serious treatment-related adverse events, you can see they're comparable. Treatment withdrawal, comparable more or less. Immune-related adverse events were more common in the Tizo group. However, most of them were actually grade 1 and 2. This is an overview for all the detailed immune-related adverse events. Here you can see the 2 deaths, which are the grade 5, pyrexia and EBV occurring in the Tira. And I don't know, I found it interesting that decreased appetite was almost double with placebo and Tizo. Okay. So it seems from this trial that, in a way, the addition of Tira to Tizo can provide more clinical benefit than Tizo monotherapy. This is the wording that they used in the manuscript, but I think it needs more context. Maybe rather clarifying that specifically greater benefit was seen for those patients with the TPS of more than 50 compared to the total. And then still here we have some concerns considering that for this population, 65% of them were more than 75. So we can still argue that maybe there's some outliers in this group that are skewing this trend. So I think it would be interesting if the authors were able to provide specifically the TPS scores for those who responded in a more granular way, just to get a sense of, because there is a difference when we say Tira is viable for patients with higher than 1% PD-L1 expression, or saying higher than 75 or 90. So we'll get to that as well. There was limited benefit in TPS 1 to 49. Perhaps other options that could be explored in this context, chemotherapy with some IO regimen, and this is already being investigated in the CITYSCAPE 06 trial. Higher incidence of adverse events with the combination, which is not new, as we've seen with previous IO combinations, Ipi-Nivo. And also, in this trial, we had longer duration of response with those patients, which means longer duration of treatment, which means longer follow-up, higher likelihood of getting those, documenting those adverse events. This trial was actually limited by inadequate power to detect all clinically meaningful improvements. This would have been an issue if the trial was negative, because even if it was negative, due to the limited power, we couldn't rule out the possibility of it being effective. But in this instance, it was a positive trial. Other anti-TIGIT trials with anti-PD-1, PD-L1, there are ongoing phase 3 trials. The same group are starting the SKYSCRAPER 01 trial. And there is a phase 1 trial with an anti-PD-1 with bevacizumab. And actually, the SKYSCRAPER is currently being limited to high PD-L1. So not PD-L1 positive, high PD-L1, so more than 50% as on their clinicaltrials.gov report. My comments, I would say the PFS versus overall survival point, in a way, it's always, there's room for debate for this. Perhaps PFS allows for sooner results, but maybe it doesn't always reflect the overall survival. And yet you can say PFS still, even if it doesn't translate to overall survival, it has some value for patient's preference. In addition, PD-L1 TPS groups and their reflection of reality. Again, this is not an issue specific to this trial, but I would say there perhaps we need something more reflective of the complex dynamic of PD-L1 in solid tumor. And I think it was a missed opportunity in this trial to do TIGIT-based biomarkers, like something as simple as TIGIT or the receptor for TIGIT, the PRV, immunohistochemistry. I don't know if RNA-seq was possible. just some TIGIT-based biomarkers, since this is actually the first trial to check the both combination and randomized trial setting. And to take a look at, just to take the results of this trial in context and see where actually on the big picture level, these are some numbers for PD-L1 TPS prevalence across different real life data studies. So we have the less than 1%. This group seems to be almost 50%, ranges in the literature from 41% to 56%. The 1 to 49% seems to be around 30%, and the more than 50% is around 20, 25-ish based on the three studies. And again, as we recall, in our study, those patients who had more than 75 were 75% of the cohort. I know it might be confusing with other percentages, but I would say the take-home message from these numbers specifically, that this trial had a big chunk of those higher than 50% in the extreme high distribution. So we need to take it into consideration, and hopefully the follow-up with the phase 3 trial, which is the CITYSCAPE-01, will help address some of those questions. Lastly, I would like to thank you all. I know this is my last day of the second week with Dr. Backstrom. I can't thank you enough for all the education and all the guidance you provided me with. Dr. Scott as well, thank you so much. You've been a great guidance through. And Costa, see you definitely next week. And Erin, I'm gonna enjoy more conversations with you during the remaining 2 weeks as well. So thank you all for listening. And if you have any questions and discussion.